Milestones in Algology. Module number 2 discusses the incidence and deleterious effects of both acute and chronic pain. It also presents clinical observation as well as clinical and basic science research, which strongly support the need to personalize or individualize the treatment of pain patients. The treatment of pain includes the use of both a multidisciplinary as well as multimodal approaches. Let us first consider acute pain. The magnitude of the problem of acute pain has been estimated to be of about 56 million Americans suffering from acute pain, either for post-surgical or post-traumatic pain. Before the introduction of acute pain services in major hospitals, it was estimated that less than 50% of patients suffering from acute pain obtain acceptable pain control. We can say that acute pain is most frequently a reversible neurologic disease. In 1914, Dr. George Washington Cryle, already mentioned in module number 1, wrote an extensive book entitled Anosi Associations, meaning without the association of nocere or nociceptions. A large portion of this book was dedicated to surgical outcome. Dr. Cryle demonstrated that by preventing emotional stress and physical pain, he was able to decrease mortality by more than half. In 1908, before applying these interventions, post-operative mortality in his hospital was at 4.3%, certainly a very high by our standard. But we must remember that at that time there were no antibiotics, anesthesia was still relatively new, and surgery was associated with high mortality. 4 years later, after applying Anosi associations, mortality rate declined to 1.9%, and the results were reproduced the following year. Dr. Cryle was convinced that to decrease the mortality, he had to decrease both the emotional stress associated with surgery as well as the physical nociception. To decrease the stress, he would not tell the patients the day of the surgery, and he would heavily sedate them before going to the operating room. He would use a combination of general and spinal anesthesia, and to further prevent the generations of nociceptive impulses, he would infiltrate with a long-acting local anesthetic each tissues layer before the incision. Any remaining post-operative pain was treated with the properly titrated morphine for several days. Dr. Cryle published this data, but the medical establishment did not accept his method, and emotional stress associated with surgery and nociceptive pain continued to be poorly treated for many more decades. Dr. Cryle's meticulous technique of infiltrating the tissues with long-acting local anesthetics before the incision to prevent the generation of nociceptive impulses at the site of surgery and thus decreasing post-operative pain found a scientific evidence about 80 years later from the research of Dr. Alan Basbaum. Dr. Basbaum is a leading pain researcher and professor and chairman of the Department of Anatomy at the University of California at San Francisco. Among many other basic science studies on nociception and pain, he describes some of the events associated with inflammatory or traumatic processes typical of postoperative pain. The nociceptive impulses generated at the inflammation site are transmitted to the spinal cord. Substance P, a neurotransmitter, is released to allow the transmissions of the impulses from the peripheral nociceptive nerves to the spinal thalamic tracts. However, substance P is also centrifugally released near the site of the nociceptive stimuli. This causes degranulations of mast cells and release of histamine that contributes to the increase of the inflammatory process, and in so doing establishing a vicious circle. Dr. Cryol's infiltration of tissues with local anesthetic would prevent the development of this condition. A few of the concepts of Dr. Cryol's method have been incorporated in the 1990s description of preemptive analgesia, which would be better described as preemptive antinociception, as the goal is to prevent the nociceptive impulses from being generated, or at least to prevent them from reaching the central nervous system. 40 years after the publication of Dr. Cryol's book in 1914, Dr. John Bonica, internationally recognized to be the father of pain medicine, published an extensive book entitled The Management of Pain. In this book, he devoted an entire section, 20 pages long, to the descriptions of the deleterious effect caused by postoperative pain. Some of these deleterious effects were identified by the many scientific discoveries that had occurred since the publication of Dr. Cryol's book. The original figure, published in 1953, and showing the interconnection caused by the pathophysiology of postoperative pain, was replaced a few years later by an easier to understand drawing. In these presentations, to facilitate the explanations, the one-page design has been divided in two subsequent slides. Bonica analyzed and described the various steps associated with the generations of acute pain, from the triggers of nociceptions to its transmission and to its cortical perception as pain. At the local level of injury or surgery, there is a release of intracellular substances which cause allodynia and hyperalgesia, which contributes to the development of a vicious circle. As the impulses reach the spinal cord, they trigger segmental reflexes consisting mostly of vascular and muscular spasm. The vascular spasm can cause ischemia. The muscular spasm affects not only the voluntary muscle, which decrease voluntary muscle activities such as ambulation, deep breathing, and coughing, but also the visceral muscle with the bronchial spasm, decreasing gastrointestinal and urinary functions, which cause abdominal distensions followed by nausea, vomiting, ileus, and constipation. As the nociceptive impulses travel along the spinal thalamic pathways, they trigger suprasegmental reflexes, consisting in the release of stress hormones and catecholamines, causing hyperglycemia, tachycardia, and hypertension. The arrival of nociceptive impulses to the cerebral cortex triggers the perception of pain, which in turn causes psychodynamic emotional responses such as anxiety and fear, as well as decreased motivations and immobility. This slide clearly shows one significant negative effect that severe pain in the upper abdomen and/or chest can cause. The muscular spasm triggered by severe pain reduces the functional residual capacity. Furthermore, severe chest or upper abdominal pain of whatever cause prevents deep breathing and coughing. The inability to cough causes accumulation of secretions in the lungs. This secretion, especially in the distal bronchioles, cause ventilation perfusion abnormalities. A partial obstruction of a bronchiole may allow air to enter freely in the alveolus but not to exit. This will cause overdistension of the alveolus due to the increased intraalveolar pressure, which will also prevent blood circulations in the alveolar capillaries. This condition prevents the gas exchanges between the blood and the alveolar air. Equally, gas exchanges will not occur if the secretion completely obstructs the bronchioles, causing atelectasis. This slide further summarizes the effect of acute pain on respiratory system. You can see that acute pain can cause a decrease in the tidal volume, a decrease in the vital capacity. The functional residual capacity is also decreased, which leads to atelectasis and ventilation perfusion inequalities. There can be a decrease in alveolar ventilations. Also, acute pain causes decrease in mobility with the development of hypostatic pneumonia. The negative cardiovascular effects caused by severe pain are related to the release of catecholamines. They produce a sympathetic overactivity, which cause an increase in the heart rate, increase in the peripheral vascular resistance, increase in blood pressure, and an increase in cardiac output. All these enhanced activities require an increase in oxygen use, and therefore delivery to the myocardium. If this is not possible because of coronary vascular disease, the patient is going to develop myocardial ischemia, angina, and even myocardial infarction. As mentioned earlier, severe acute pain will have significant negative effects on both the gastrointestinal and urinary systems. Also, these effects are caused by the sympathetic hyperactivities. In the gastrointestinal system, there will be an increase in secretions and an increase in the smooth muscle sphincter tone, as well as a decrease in the intestinal mobility. This leads to abdominal distension, which causes both nausea and vomiting. The ileus, caused by severe pain, produces constipations. On the urinary tract system, the increased sympathetic tone will increase the activities of the urinary sphincter with urinary retentions and further abdominal distension. In the mid-1940s, in both Tacoma and Seattle, there were two anesthesiologists with a strong interest in regional anesthesia and analgesia. At the Virginia Mason Hospital, Denny Moore was studying, and popularizing regional anesthesia techniques. In Tacoma first, and at the University of Washington later, these efforts were led by John Bonica with the support of Bill Kennedy and Terry Murphy. One of the results of this interest was the development of a dedicated obstetrical anesthesia and analgesia service. The service provided continuous coverage by anesthesiologists who use mostly intraspinal blocks. In the mid-70s, the awareness from the pioneer studies of Bonica's of the serious deleterious effect of acute pain, together with the great familiarity developed with the epidural obstetrical analgesia, induced the anesthesiology department of the University of Washington to provide epidural block using local anesthetics after upper abdominal or thoracic surgery to high-risk patients. However, it was soon learned that the sympathetic block caused by the local anesthetic in debilitated post-surgical hypovolemic patients caused severe morbidity, and the program was quickly discontinued. The discoveries in the late 70s and early 80s that intraspinal morphine provided intense analgesia without sympathetic and motor block caused the reassessment of epidural analgesia for the treatment first of postoperative and later also post-traumatic pain using intraspinal opioid analgesia. In 1985, the first dedicated acute pain service was started at the University of Washington. In collaboration with the very active thoracic surgeons, all eligible consenting patients underwent the placement of an epidural catheter before the surgery. Preservative-free morphine was used as the epidural analgesic agent. The results were very encouraging and prompted the publications in the Journal of Anesthesiology in 1988 of an article describing both the benefits and the organization of an acute pain service. In 1987, Yeager and his colleagues published a seminal study in the Journal of Anesthesiology. These researchers compare in a randomized clinical trial the postoperative outcome of patients who receive epidural anesthesia and epidural postoperative analgesia versus the control group who received the standard general anesthesia and postoperative parenteral opioids analgesia used in their hospital. The patients included in the study were all high-risk surgical patients. The average patient was 72 years old and suffered from cardiovascular and or pulmonary comorbidities. The patient had been optimized to undergo a major surgical procedure. The consenting patients were randomized to receive either epidural anesthesia and epidural postoperative analgesia or to be in the control group. 53 patients were studied, 28 in the epidural group and 25 in the control group. These were the results. In the epidural group, there was no mortality. The control group had 16% mortality. Due to the number of patients studied, this difference in mortality did not reach statistical significance. All the other parameters, however, were statistically different in favor of the epidural study group. This included cardiovascular failure, respiratory failure, major infections, number of days in the intensive care unit. For the hospital administrators, whose major interest is based on economics, the focus should be on the average total cost per patient. The average cost per patient in the epidural group was about $11,000 less than the control group. We must remember that the $11,000 were dollars of 1987. This compares to a today value of about $40,000 per patient. It is very clear, therefore, that hospital administrators should actively support an acute pain service, even if the service does not bring large revenues to the hospital, because, besides providing more humane care, it saves the hospital a significant amount of money. To underscore this concept, before the development of an acute pain service, the average length of hospital stay after a thoracotomy was of 14 days. Now, with effective postoperative analgesia, it is of 4 to 5 days duration. Let us now consider chronic pain. In 2010, the United States Congress, with the introductions of the Affordable Care Act, wanted to know the impact of pain on the American society. A study was mandated, and the Institute of Medicine was selected to carry out the project. In 2011, the Institute of Medicine released a comprehensive evaluation of the effects on pain entitled Relieving Pain in America, a Blueprint for Transforming Prevention, Care, Education, and Research. The report makes two major points. Chronic pain is most often a non-reversible neurologic disease, and chronic pain affects about 106 million Americans every year. These reports summarize the data related to all different types of chronic pain and of different intensity. Several studies carried out in different industrialized countries report that about 10% of the adult populations suffer severe incapacitating chronic pain. In other words, pain which prevents the individual to be properly functional and relegate him or her to the status of being an invalid. Therefore, it is estimated that in the United States, between 25 to 30 million people are severely impaired by chronic pain. This slide enumerates the most common chronic pain syndromes. They are headaches, back pain, arthritis and fibromyalgia, neuropathy caused by chemotherapy and diabetes, reflex sympathetic dystrophy or complex regional pain syndromes, phantom and stump pain, post-thoracotomy and postherpetic neuralgia pain, sickle cell disease and hemophilia, pain associated with cancer and HIV. Pain is a poorly visible disease. Its total symptoms load is mostly invisible to most healthcare professionals. It can be compared to an iceberg. The healthcare professional may hear the patient say, "I'm in pain," and can observe some pain behavior such as moving slowly, limping, unwilling to move, or even unwilling to talk. In reality, the patient and the family, since we must not forget that the family of a patient suffering severe pain is also greatly affected. They both experience lack of sleep, tiredness, and decreased functioning, which is often associated with a decrease in the income. Psychological depression, a possible depression of the immune system with increased incidence of other illnesses. Animal studies have demonstrated that severe pain depresses the immune system. However, we do not have human studies clearly showing this effect. We do know that stress depresses the immune system from the studies of Hans Selye of several decades ago. And what can be more stressful than being in severe, unrelieved, persistent pain? Severe pain also causes alteration of family function, as well as increasing expenses, especially medical expenses. The Institute of Medicine report of 2011 estimated that the cost to the American society of chronic pain is of over 600 billions, not millions, billions, every year. This is because about 300 billions is the cost of medical care to treat patients with chronic pain, and another 300 billions is lost in productivity because patients with chronic pain, they are not able to function as patients without this disease. I like to show this picture because each of these three individuals has contributed with this research, knowledge, and observation to some of our understanding about pain. Job Bonica is in the background. I have already described a few of his many contributions. John Liebeskind was one of the leading pioneers in the field of pain research and trained many of the second generations of leading researchers, clinicians, and educators. John Paul II wrote and discussed issues about pain and palliative care. In 1987, John Paul II met with a group of international pain specialists and their family. During the meeting, he gave John Bonica a letter. This is the copy of the letter that John Paul II issued during the private audience. In it, he reflects on the experience of pain, both from religious and human perspectives. When I read the letter, I was very surprised and impressed that a religious leader recognized that physical pain can cause the oppressions of the mind and the spirit. This is a concept that the majority of healthcare professionals fail to appreciate. I once heard an anecdote that clearly supports this observation. A nun dying of metastatic breast cancer was transferred to an hospice. Several days later, after effective pain therapy had greatly decreased her pain, she thanked one of the hospice workers and said, "Now that my pain is tolerable, I can finally pray again." Clearly, the severe cancer-related pain had completely oppressed the mind and spirit to the point of preventing her from praying, one of the things that she has done all her life and that was so essential for her. The following short video shows the end of the Papal audience when Ron Melzack, one of the authors of the gay control theory, which I mentioned at the first module, brings to the attention of John Paul II the fundamental basic concept that pain and suffering is a problem in its own rights.
There is enormous pain and suffering in the world.
Yes.
Tremendous. And we work very hard to make people aware that pain and suffering is a problem in its own right. And Dr. Banica has played a tremendous role in the world to tell this to people.
It is your mission, maybe said, your vocation, duty. And so I am deeply convinced since so many years, for as a young priest I worked also with the physicians, with the doctors,
Yes.
and that you have a special participation in the mission of our...
John Liebeskind, in the 80s and early 90s, carried out a series of animal research, which at the time was perfectly legal, but now will not be allowed. The research consisted in exposing rats to inescapable pain. And certainly this is an awful thing to do, but let us reflect. What happens to a patient who has severe pain and that pain is not being properly treated? Isn't that patient experiencing inescapable pain? He found that these rats develop a significant depression of their natural killer cell. When these rats were injected with a certain number and certain type of cancer cell, most of the rats develop cancer and die. The control animals, the rats not exposed to inescapable pain, their natural killer cells were unaltered, and when they were injected with the same type and same number of cancer cell, they did not develop cancer. It is clear from these animal studies that severe pain can be a great stressor. And we do know that stress decreases the immune system, and this decrease in the immune system can predispose individual to different types of illnesses and diseases.
Pain is simply another stressor. We have no reason to believe otherwise. It happens to be a very effective stressor from the standpoint of immune suppression and tumor enhancement. There's nothing so fascinating then about this finding from the standpoint of a new observation. I think it's more interesting from the standpoint of politics than I do from the standpoint of science, and I would say that to anyone. We believe then that when more evidence of this sort becomes available, that we can hope that we'll be able to convince health professionals everywhere that pain is not merely an unpleasant something, an unpleasant event, that's something that to be borne with stoic grace and a brave smile, but that it can be a significant pathogen, as John Banica has told us last night, that it can be itself an aggressive disease that can have an impact on morbidity even on mortality. In short, that pain can kill. Thank you very much.
Let us now consider the need of personalizing or individualizing the care of pain patients, which is a basic concept of pain therapy. It is always highly rewarding in medicine when a clinical observation is then proven by clinical research and basic science research. This happened to the concept of personalized care. I have already mentioned George Washington Cryle, and in 1914 he wrote that morphine should not be given in one dose, but in repeated doses until the physiological effect is obtained. Now this is what we now call titration of medications. In order to give the right amount to the patients, we have to give small dosages until the effect of the medication is obtained. This concept was proven by clinical research about 70 years later. Dr. Dodson from England studied 49 patients undergoing hysterectomy. In order to minimize the variable, all the surgery was done by one surgeon using the same surgical technique. The patients were then allowed to use as much morphine as needed to control their post-operative pain. The results were very striking. We see that two patients require 1.2 milligrams of morphine injected every 4 hours. And at the other extreme of the graphic, one patient requires close to 35 milligrams of morphine every 4 hours. This makes a difference or a range of 30 folds. Even if we want to exclude the two outliers on the right, we can see that the different amount of morphine required to control pain from an identical surgical procedure can vary up to 15 folds, 15 times. It is then clear that if we use the same dose of medications for every patient, the majority of the patients will either be undertreated or overtreated. The previous slide should be known by every healthcare professional who takes care of patients suffering pain, as it clearly shows the importance of individualizing the dose of an analgesic. This concept was further proven by basic science studies. There is a condition exhibited by mice called stress-induced analgesia. If a mouse is made to swim in cold water, the mouse develops some analgesia. In other words, the pain threshold increases. A group of Polish researchers studied the phenomenon and found that the analgesic effect was not equal among all the mice studied. Some developed more and some less analgesia. They started a collaborating effort with John Liebeskind. Instead of just collecting all the data, finding an average, a range, and a standard deviation, as it is usually done in research, they elected to take the 5% of the mice that developed the highest amount of analgesia and to mate them among themselves. This selection and mating was done for 5 generations. At the same time, 5% of the lower responders were selected and mated for the 5 generation. At the end of the study, the two groups were extremely different in regard to the response to stress-induced analgesia. The fascinating point is that previous studies had found that stress-induced analgesia parallels morphine analgesia, as the possible mechanism of action of stress-induced analgesia is the release of endorphins. At the end of the study, to produce the same amount of analgesia between the two groups, the dose varied 100-fold, 100 times. In the following video clips, John Liebeskind reports the result and the implications of this study.
That in the fifth generation were enormously different from the standpoint of their sensitivity to the analgesic effects of morphine. And so it took 100 times as much morphine to produce analgesia in the low analgesia line, the LA line, as in the high analgesia, HA line. 100 times as much morphine. Assuming that any of this has anything to do with people, which is a big assumption, of course, I think at least we can understand that this mouse genetic work is showing that there are extremely important constitutional or genetic factors for determining the response of the organism to injury, because that's, after all, what we're looking at. We're looking at a response to stress, a response to injury, and that we can understand then that this new understanding about the importance of constitutional factors, not saying, I am after all a psychologist, not saying that environmental factors, experiential factors are not important. They may be enormously important. The importance of one does not subtract from the importance of the other. But the fact that there are important constitutional and genetic factors, we think might serve in the public mind to decriminalize pain a little bit and to make pain complaints seem less a reflection of weakness of character. And so we're hopeful that it will have that effect on the attitude of the general public in relation to pain.
Module number 3 of Milestones in Algology focuses on myths, biases, misconceptions, as well as reflecting on some logical considerations.